morning, everybody. Mr. Blackwell.
Good morning, Your Honor, Counsel, ladies and gentlemen. We'll call our first witness this morning, Dr. Martin Chauvin.
Raise your right hand, please. Do you swear or affirm under penalty of perjury that the testimony you're about to give will be the truth and nothing but the truth?
I do.
And doctor, if you wouldn't mind removing your mask for your testimony.
Yep.
And also, to make sure the microphone is properly placed, we're going to have you state your full name, spelling each of your names.
Martin Tobin, Martin Tobin.
Mr. Blackwell.
Good morning, Dr. Tobin.
Good morning, Mr. Blackwell.
Would you tell us what's your current employment?
I am a physician in pulmonary and critical care medicine
And whereabouts?
in Chicago at Hines VA Hospital and Loyola University Medical School.
And is Hines VA Hospital a large facility?
It used to be the largest VA hospital in the country. I think it's now been superseded by one or two others.
And you specialize in pulmonology?
I specialize in pulmonology and in critical care medicine.
Would you tell the jury what pulmonology is?
Pulmonology is the study of the lungs. It deals with all diseases that affect the respiratory system. So the lungs, the chest wall.
So what are the various elements, components of the respiratory system other than the lungs and chest wall?
I mean, the respiratory system begins at the nose and the mouth. It goes down through the back of the throat, down through the windpipe, out through the bronchial tubes, and then down at the bottom, down to the alveolar air sacs. These are the small grape-like structures at the bottom where all the gas exchange takes place, where oxygen gets in and carbon dioxide is removed.
So this is the system for getting oxygen into the body.
Correct. That is the prime purpose to get oxygen in.
Now at Hines Hospital, do you work in the intensive care unit?
Yes, I work in the medical intensive care unit.
And that's considered critical care?
Same as critical care. These words all have the same meaning.
Is critical care different from emergency medicine?
Yes, it's very different than emergency medicine. Emergency medicine is kind of the front door of the hospital. That is a triage area where you separate out where people need to go, whereas the critical care is where you take the very, very sickest people.
What kind of patients do you see in the ICU?
In the ICU, probably more than half of them are patients who are requiring mechanical ventilation. So they're on a respirator to help them with their breathing. Then another substantial number will not be on a respirator, but their primary problems relates to their lungs. So that might make up 70% or so. And then the remaining patients will have drug overdoses, alcohol withdrawal, diabetic coma, sepsis, things like that.
Do you only see the patients in need of respiratory care?
No, once they come into the ICU, they're our patients. I'm the primary care physician for everybody who comes into the ICU.
And how long have you been a physician, sir?
I've been a physician for 3 months short of 46 years, so over 45 years.
And where did you go to school?
I went to medical school in Dublin, Ireland, and I took my degree there.
Not that anybody noticed the accent, but but are you from Dublin?
No, I'm not from Dublin. I'm from a small village called Freshford in County Kilkenny in rural Ireland.
What degrees do you hold?
I'm sorry?
What degrees?
The degree I hold is the MB degree, which is the Irish equivalent of the American MD. And then subsequently, I got an MD through research.
Are you currently licensed?
Yes, I'm licensed in the state of Illinois. In the past, I was licensed in Ireland and England and a number of US states, but I've let them all lapse because the only place I'm practicing is in Illinois.
Are you board certified?
Yes, I'm board certified in internal medicine, pulmonary medicine, and critical care medicine.
So you still are actively caring for patients?
Yes, I was taking care of patients in the ICU last week, and on Monday, I go straight back into the ICU again.
How long have you held positions at Loyola University School of Medicine?
I've been at Loyola and Hines for 32 years almost.
Before going to Loyola, were you practicing medicine somewhere else?
Yep, I spent 7 years at the University of Texas at Houston.
Did you also set up a sleep clinic in Houston?
Yes, I did. And that would have been in the early 80s. So I set up one of the very first sleep labs in the United States for evaluating patients with obstructive sleep apnea.
So how do sleep disorders fit within your expertise?
Because this is related again to breathing and the problems with sleep, particularly people who snore. And the people who snore during the nighttime, they occlude their upper airway and they can totally stop breathing 500, 600 times a night. And during that time, the level of oxygen in their blood will go very low. And the basic problem in sleep apnea is because the soft palate, I mean, the roof of your mouth is your hard palate. And then just if you look in the mirror, it's that little piece that's hanging down at the back, and that's your soft palate and uvula. And that jams in against the back of your throat and it gets occluded 500 times a night in somebody who has sleep apnea.
And does that kind of research or science or medicine relate to your work in this case?
Yes, it's extremely pertinent to the case of Mr. Floyd because obviously in sleep apnea, the problem is at the back of the throat. And as we will see in Mr. Floyd, the central problem of where the obstruction is occurring is in the hypopharynx, which is again at the back of the throat. So it has an awful lot of overlap to patients with sleep apnea.
We'll come back to the hypopharynx in a little bit. Are you also engaged in medical research?
I'm sorry?
Are you also engaged in medical research?
Yes, I do. I've been doing medical research since the early 80s, since about 1981.
What kind of research have you been doing?
All of my research is related basically to breathing. So it is kind of looking at breathing in patients with lung disease, people who have lung disease who walk in the door to the clinic, and also patients who are in the ICU, and particularly patients who are requiring mechanical ventilation. But then I do a lot of research that has absolutely nothing to do with clinical medicine, just to know how people breathe.
Have you authored a textbook on the subject of ventilation?
Yes, I've authored a large textbook on mechanical ventilation that's called The Principles and Practice of Mechanical Ventilation.
So I'm showing the cover of your textbook here on the camera. Is this the book you're referring to?
That is correct.
1,500 pages.
Correct, 1,500 pages, yeah.
Are you familiar with the Lancet, Lancet medical journal?
Yes, the Lancet is one of the top medical journals in the world.
And does the Lancet medical journal refer to this book as the Bible on mechanical ventilation?
Yes, it has called it that.
Have you authored other books also?
Yes, I am.
Roughly how many?
I think I've published 8 or 9 other books.
And all related to respiration or respiratory failure?
Correct. They're all on different aspects of the lungs.
Have you published articles and abstracts also?
Yes, I have.
Approximately how many of those?
I lose count, but I think I've published more than 750 probably, or something like that.
Have you published in the New England Journal of Medicine?
Yes, I've published several articles in the New England Journal of Medicine.
The Journal of the American Medical Association?
Yes, likewise.
Are those two of the most respected medical journals in the world?
They are for clinical work, yes.
Have you also held editor positions at medical journals?
Yes, I was editor-in-chief of the journal called the American Journal of Respiratory and Critical Care Medicine. So that's the premier journal in the world for all lung disease. It's also the premier journal in the world for intensive care medicine. And it's the official journal of the American Thoracic Society.
Have you taught and lectured outside of Illinois and or Texas?
Yes,
Generally where?
I've lectured all around the world. I mean, I've lectured in more than 30 different countries around the world, and probably the vast majority of states within the United States.
Well, Minnesota is one of the states in the United States. How about Minnesota?
I've lectured in Minnesota. I've been in the Mayo Clinic several times as a lecturer.
Were you given an award from the Mayo Clinic?
Yes, I was given an award called the Balfour Lecturer in the Mayo Clinic, and they give it out to one doctor every 10 years. And it's only to one doctor. It doesn't matter what specialty. So it could be around neurosurgery, gynecology, whatever. They just pick one person every 10 years.
And was it for anything in particular that you were recognized by the Mayo Clinic?
No, just for my work in clinical as a researcher in clinical medicine.
Have you also published in basic science journals, such as the Journal of Applied Physiology?
Yes, I've published a lot of work on basic science that wouldn't necessarily be directly related to medicine in the Journal of Applied Physiology.
The jurors may not be familiar with what physiology is as a science. Could you generally explain it?
Yeah. I mean, physiology is basically how the body works. You want to know the science of how it works. You want a deeper understanding of what are really the mechanisms that make the body does what it does.
Within the field of physiology, is there a particular focus or interest you have?
I'm primarily interested in breathing in the bigger area. And so with breathing, that would mean how the brain regulates your breathing, how the brain sends signals down to the muscles that control your breathing, your diaphragm, your rib cage, and then how you expand your chest and how you overcome forces within your chest, like resistance within your chest and all the rest of it, to get air moving in and out of your lungs. And then the particular forces that you generate in terms of the pressures within your chest that will enable breathing to occur, with the ultimate purpose of getting oxygen in and getting rid of carbon dioxide.
And you consider this a part of the study of medicine?
It's not quite as part of the study of medicine. It's really quite separate because it's more the basic physiology. So it's more in the realm of math and physics, but then it's applied over, because to be a good doctor, you need to have a good knowledge of science, but the science part is really separate from the medical part, and it's to try and hone down on the science as best as possible.
How long have you been working in respiratory physiology?
Since 1981, so 40 years.
And what exactly drew you to the physiology of breathing?
I mean, because I was going into pulmonary, at that stage, I knew, as already directed, I had spent 5 years doing lung disease, and I just wanted to really know how you breathe. And I wanted to come up with new knowledge, because everybody thought everybody knew everything of how to breathe. And I thought it would be fun to find a lot of new stuff.
So, doctor, do you know of others kind of in your field who have been studying respiratory physiology for 46 years?
No, I mean, I know an awful lot of them along the way, but I mean, I would know no more than a handful or less of people who are still doing physiology at the patient's bedside. after 46 years.
So, doctor, let's change subject and talk a little bit about your experience at work as serving as an expert. Have you served as an expert witness before?
Yes, I have.
What types of cases?
Practically all of them have been in medical malpractice. So I've done it for both the plaintiff, for the patient side, and I've done it for the defense, for the physician side.
Have you ever been involved in a criminal case before?
No, I have never been involved in a criminal case.
Have you testified in court before?
I've testified in court. I don't keep track of the numbers, but I suspect I've been in court about 50 times.
Would you tell the ladies and gentlemen if you're getting paid for your time in this case?
No, I am not getting paid.
And why is that?
Well, when I was asked to do the case, I thought I might have some knowledge that would be helpful to explain how Mr. Floyd died. And since I'd never done this type of work in this nature before, I decided I didn't wish to be paid for it.
So did you volunteer to the state of Minnesota, or did the state of Minnesota call you?
The state of Minnesota contacted me.
What were you asked to do, Dr. Tobin?
I was asked to review the medical records related to the case. These were medical records from Hennepin County. Then there were a number of interviews of people that were interviewed. I was given a long list of these, and primarily it was related to looking at a large number of different videos. But of course, then the big part was that I needed to read on the scientific background of all the various aspects related to it.
So let's talk about your opinions with respect to this case. Have you formed an opinion to a reasonable degree of medical certainty on the cause of Mr. Floyd's death?
Yes, I have.
Would you please tell the jury what that opinion or opinions are?
Yes, Mr. Floyd died from a low level of oxygen, and this caused damage to his brain that we see, and it also caused a PEA arrhythmia that caused his heart to stop.
And by PEA, you mean pulseless electrical activity?
Correct. It's a particular form of an abnormal beat of the heart, an arrhythmia, and a particular form of it.
Is this what some persons might refer to as asphyxia?
Yes, it has been called asphyxia. To me, it's not terribly helpful. It just, what we're really talking about is a low level of oxygen. Other people talk about hypoxia. That again is just a Latin term meaning a low level of oxygen. So all of this is just really other words for a phenomenon that is a low level of oxygen.
Have you formed an opinion to a reasonable degree of medical certainty as to what the cause is or was for the low level of oxygen in Mr. Floyd?
Yes, I have.
Would you tell us what that is?
The cause of the low level of oxygen was shallow breathing, small breaths, small tidal volumes, shallow breaths that weren't able to carry the air through his lungs down to the essential areas of the lungs that get oxygen into the blood and get rid of the carbon dioxide. That's the alveoli at the bottom of the lung.
Dr. Tobin, would using a short video that you prepared help you explain to the jurors how oxygen gets into the lungs and the body? How we take in oxygen?
Yep.
I'm going to show you what's been marked as Exhibit 950. Can you describe first what that is?
So here we're looking at the lungs inside a body, and we see here that you can see the windpipe up at the top, the trachea, and then that splits into the bronchial tubes. And also you can see the diaphragm down at the bottom. And when the diaphragm contracts, there will be air moving.
The jurors can't see it yet, so I'm just having just identify.
Oh, I'm sorry, terribly sorry. I apologize.
Yeah, I'm going to offer it, Your Honor. Exhibit 950.
950 is received.
Yeah, please proceed. We can, we'll display it so the jurors can see it.
Okay, so now we're looking, and you can see the contraction of the diaphragm. That's the kind of pink area down at the bottom. We see air going down through the windpipe and then proceeding down to the bronchial tubes. And then it was going to continue down the bronchial tubes until it will reach out to the air sacs, which will be the alveoli. And now we're seeing that we're moving down here. And these are like the grape-like structures down at the bottom. And this is where all the action occurs. The oxygen goes across those air sacs, and also the CO2 goes across them, then it's expelled back out. So that's everything in a very rapid video.
So then what happened in the case of Mr. Floyd that relates to the shallow breathing that resulted in his low oxygen?
So there are a number of forces that led to that the size of his breath became so small. And so there are a series of forces higher up that are leading to that. And the main forces that are going to lead to the shallow breath are going to be that he's turned prone on the street, that he has the handcuffs in place combined with the street, and then that he has a knee on his neck, and then that he has a knee on his back and on his side. All of these four forces are ultimately going to result in the low tidal volume, which gives you the shallow breaths that we saw here. And so the air will not be able to reach those air sacs we just saw in the video where the oxygen is exchanged and the carbon dioxide is removed.
Doctor, is there a concept that in the respiratory medicine field known as dead space?
Yes, there is.
How does that relate to Mr. Floyd?
So if you think of the video back all the way until you saw those clusters of grapes, where you saw the blood vessels surrounding the alveoli, everything up to there is dead space. So as you're breathing in through your nose, your mouth goes down through your windpipe, down through the bronchial tubes, radiating out until it reaches the air sacs. Up till you get to the air sacs, it's all dead space, because the reason we call it is because no oxygen can get across those bronchial tubes. No carbon dioxide can get across it. The oxygen and the carbon dioxide, the only place that gets across is those little grape-like structures. So everything in the lungs before that is dead space.
So you mentioned several reasons for Mr. Floyd's low oxygen, and I just want to capture those for the jury, and then we'll talk about them. You mentioned one, handcuffs and the street. Right?
Correct.
You mentioned knee on the neck.
Yep.
Sorry for my writing. You'll know what I didn't get an A in school. The prone position.
Yep.
And then the knee on the back, arm and side. Were those the four?
Yep, these are the four.
Okay. So we want to talk about each of these, but before we do that, might it be helpful for explaining your testimony to the jury for them to see the relative positioning of the various officers on Mr. Floyd's body when he was subdued on the ground?
Yes, I think that would be very helpful.
Did you assist in preparing an illustration to show the relative position of the officers on the ground?
Yes, I did.
And let me show you what's been marked as Exhibit 949. Could you just tell us, describe generally for the record what it is?
I mean, I watched the videos and certain segments of the videos hundreds of times, and it's very difficult to kind of get an overall view of where everybody is positioned because you're seeing different videos from different angles. And so the artist has taken all the different videos here and he's combined them into one moment in time. And you can see here, and also he will remove the police vehicle, so you're going to get a better view. So you're looking kind of at a bird's eye view of where Mr. Floyd is lying and where the officers are positioned in relationship. to Mr. Floyd.
So the purpose of this is to show the relative positions of the officers on the
Correct.
body. Your Honor, we would offer Exhibit 949.
Any objection?
No, Your Honor.
949 is received.
So what point in time, if you told us that this is at a particular point in time?
Right, it is a particular point in time. I don't remember the exact minute, second at the top of my head, but it is like,
It was 8:21 and 44 seconds.
that's exactly correct.
About right.
Yes.
Thank you, Your Honor.
Okay, so let's walk through Exhibit 949, Brad, if we could advance. And Doctor, tell us what we're seeing.
Okay, yep. Now you can see the car is being rotated. You're able to see Officer Chauvin, you're able to see Officer King, and then Officer Lane down at his feet. You see underneath Mr. Floyd, and now the car is being rotated. Now the car has been removed. And so you're able to see how they're positioned at different points. In terms of with Officer Chauvin with his left knee on the neck, his right knee on Mr. Floyd's arm and chest. And then you can see here Officer Lane holding his legs, and then you can see Officer King with his knee on his torso.
So this represents a snapshot in time, as you told us. Did the officers' positions change over time as they were there on the ground?
Yes, the officers' positions changed over time, and also the position of Mr. Floyd himself changed over time, and these become relevant in how we evaluate everything.
And was it something you factored into your analysis then?
Yes.
Did you consider where Mr. Chauvin's left knee was during the encounter?
Yes, for Officer Chauvin's left knee is virtually on the neck for the vast majority of the time.
And when you say vast majority, are you able to be more
It's
specific?
more than 90% of the time in my calculations. There's certain times where it becomes difficult because you don't get a good view of where it is. So for example, I know that an Officer Chauvin's right knee is on his back 57% of the time. The reason I'm not able to say for the 43% is that I don't get a good view. I can other times don't have a good view of exactly where it is.
So did you focus on the first 5 minutes and few seconds?
Yes, I focused on the first 5 minutes, 3 seconds, because that is up to the time that we see evidence of brain injury.
So if Mr. Chauvin's right knee was on his back from time to time, at other times it was placed where in your observation?
It was placed on his arm and then rammed into Mr. Floyd's left chest. So really, whether you're making a distinction of whether the knee is on the chest per se, or whether it's on the left arm and rammed in against the left chest, from the point of view of breathing, the effects are extremely similar.
So let's turn to the number one on the. Oh yes, on the dot cam. So I wanted to turn back to the notes that the number one here that written down for the reasons you told us for Floyd's low oxygen, Mr. Floyd's low oxygen, handcuffs and the street, to talk about the first
Yep.
one. Could you first, Dr. Tobin, tell us how these various mechanisms, the four that you've discussed, handcuffs in the street, knee on the neck, prone position, knee on the neck, back, knee on the back, arm, and side. How do those mechanisms fall into your work of either respiratory physiology or clinical medicine?
They don't have an awful lot to do with clinical medicine, but they are directly related to my work in physiology. So in understanding the forces that the body has to cope with, these are crucial into terms of the various forces that are involved in physiology.
So then turning to the first one in handcuffs and the street, the very first one. What is the effect of the handcuffs in the context of what happened to Mr. Floyd?
The handcuffs are extremely important in Mr. Floyd, but the handcuffs on their own, just handcuffs per se, are not that important. It must be the handcuffs combined with the street. And it's because of the positioning of the handcuffs at the back, then how he's manipulated with the handcuffs by both Officer Chauvin and by Officer King, how they manipulate the handcuffs, and they're pushing the handcuffs into his back and pushing them high. Then on the other side, you have the street. So the street is playing a crucial part because he's against a hard asphalt street. So the way they're pushing down on his handcuffs combined with the street, his left side, and it's particularly the left side, we see that. It's like the left side is in a vice. It's totally being pushed in, squeezed in from each side, from the street at the bottom, and then from the way that the handcuffs are manipulated. It's not just the handcuffs. It's how the handcuffs are being held, how they're being pushed, where they're being pushed, that totally interfere with central features of how we breathe.
So Mr. Floyd then is pancake between the pavement underneath him and then force on top of him.
Precisely.
Now, could you help us to explain how this mechanism, the handcuffs and the street, how does it explain the shallow breathing that you've described?
Yeah. So this gets back to how we breathe. And this is fairly simple. So the way we breathe, we have two big muscles that help us with breathing. We have the diaphragm and we have the rib cage muscles. The diaphragm does about 70% of what we need for breathing, and about 30% of it comes from the rib cage. And when the diaphragm contracts or the rib cage contract, they expand the chest. And when you expand the chest, then air flows in from outside and it's coming in. And that's all that happens on inspiration. But to expand the chest, there's two crucial actions that have to happen. And we refer to these by the terms pump handle and bucket handle. So if bucket handle is simple. So if you have a regular bucket that you carry water with, and you lift up the handle of the bucket, the handle comes up like this. And so when you contract your diaphragm, you are performing a bucket handle movement on the rib cage. So you contract your diaphragm like that, and each time as you inspire, you can see it yourself. As you inspire, each of you there in the jury, you inspire, you see that your rib cage is going outwards like that. That's a bucket handle movement. The second movement that you have is called the pump handle. And this reflects to an old water pump that would be in the yard for pumping out water. And so you have the handle at the top of the pump, and you lift up the handle of the pump each time, and the water comes out the spout at the bottom. So you're filling up, get your container of water. So with that action, you're lifting up here. This refers to the front to back movement of the chest wall. So with the pump handle, your chest goes out with each breath. And so you can do it yourself. As you take a deep breath, you can feel that front to back, you're expanding your chest. The front to back expansion of your chest is with your pump handle. At the same time, you're doing both of them at the same time. At the same time you're doing that, your chest is expanding from side to side, and that's with your bucket handle. So both of these are occurring And these are vital. Without these, you can't breathe. If you don't have the bucket handle working and the pump handle working, there's nothing happening. There's no air going to get in there.
So, Doctor, do you have a photograph that you brought that would help to better understand the pump handle and bucket handle?
Yes.
Let me show you what's been marked as State's Exhibit 951. Do you recognize what this photograph depicts?
Yes.
Is it an accurate portrayal of a certain incident, disaster?
Yes.
Would it help to explain the testimony?
Yes. So this is an event that happened in England.
Dr.
Sorry,
Tobin,
I'm
just
sorry,
one
I
moment.
apologize.
Yeah, I need to offer sooner, Your Honor. We offer Exhibit 951.
Any objection?
Yeah, I have an objection to this, Your Honor. Can we have a sidebar?
All right, sidebar. Objection is sustained.
Doctor, in this case, were you able to observe whether Mr. Floyd's breathing was impacted by the handcuffs and the placement on the street?
Yes, I was.
What did you observe, Dr. Tobin?
What I observed is particularly is in terms of the hands of the police and the handcuffs, particularly on the left side. So they were forcing his left wrist up into his chest, forcing it in tight against his chest, forcing it high up. And you have to keep in mind that the opposite side of this is the street. So he was being squashed between the two sides. And so this meant that he couldn't exert his pump handle because, I mean, the street totally blocked his pump handle. There was no way he could do any front to back movement. And again, the way they were pressing in on the back, there was absolutely no way that he could do any front to back movement. Then in addition, because of the knee that was rammed in against the left side of his chest, sometimes the knee was down on the arm or in against the chest. So this would have the same effect. So basically, on the left side of his lung, it was almost like a surgical pneumonectomy. It was almost to the effect as if a surgeon had gone in and removed the lung. Not quite, but along those lines. So there was virtually very little opportunity for him to be able to get any air to move into the left side of his chest. So he was going to be totally dependent on what he'd be able to do with the right side.
Have you selected any footage from the body-worn cameras that you feel depicts Mr. Floyd's struggles to breathe?
Yes.
I'm going to show you what's been marked as State's Exhibit 944. And first, would you describe what it is?
What you're seeing here is on the...
Dr. Tobin, the jurors aren't seeing it yet. It's just describing it for the record.
Just for foundation on what it is.
They will not see this. I'm describing what I'm seeing.
For now, yes.
Yeah, okay, that's fine. What I'm seeing is that his left hand is being grabbed by the police officers. So that's a handcuffed left hand, and it's being pushed into his chest. So he's just not able to expand that. In addition, what I'm seeing.
All
I'm
we
sorry.
checked was the foundation for.
Oh, I
What it is.
apologize. I apologize. I didn't.
So let's hold off and turn it
Okay,
back.
I'm
Thank you,
sorry.
Judge.
My misunderstanding.
Your Honor, we'll offer State's Exhibit 944.
Any objection? 944 is received.
Now, Dr. Tobin, the jurors can see it.
Okay,
So
I,
would you-
I apologize.
No, it was quite all right. Would you tell us what's the
Yeah.
significance?
So
of-
I mean, now you're able to see here with the yellow arrow, you're able to see that the officer is holding Mr. Floyd's left hand. He's holding it very firmly. There's a very firm grasp on it. And then Mr. Floyd's left hand is being pushed in against his chest. Also, we're able to see just on the side that Officer Chauvin's knee is coming in, and that's compressing in against his side as well. So the ability to expand his left side here is enormously impaired. And also you're seeing that the size of the chain between the two, the right side and the left side, is very short. So his whole left arm is also being pulled over. And so it's preventing him also from expanding the right side. I've been focusing on the bucket handle and the pump handle on the left, but you can also see here that these are impaired, his ability to expand his chest. And of course, the key factor you must keep that isn't kind of in a sense seen here in one sense is the street. The street is what is having a huge effect because he's jammed down against the street. And so the street is playing a major role in preventing him from expanding his chest.
Thank you. If you could clear the screen, Your Honor.
And Dr. there is a status.
If you need to use to draw on the screen.
Thank you.
Now, did you select another still image that you observed as Mr. Floyd struggled to breathe?
Yes.
I'm going to show you what's marked as State's Exhibit 942. And if you could just identify it.
I identified.
Just mark when you
Lay down foundation if you wish.
Yes, thank you, Your Honor. So do you recognize this as the still image that you selected?
Yes, I do.
Your Honor, we offer State's Exhibit 942.
Any objection? 942 is received.
And could you tell us, Dr. Tobin, what's the significance of this image, of what we see here?
What you're seeing is slightly different on the two images, but they marry together. If you look on the left side, you see his finger is pushing against the street. You also see the hands here of the officers around his left hand. You can see the left handcuffed arm. As we discussed, you're seeing a more clear view here, how it's been really rammed into the back of his back. There's just no way he's going to be able to expand that. But with the left image, you see the finger on the street. Then over on the right image, you see his knuckle against the tire. And to most people, this doesn't look terribly significant, but to a physiologist, this is extraordinarily significant because this tells you that he has used up his resources and he is now literally trying to breathe with his fingers and knuckles. Because when you begin to breathe with your rib cage and your diaphragm. The next thing you recruit after that is your sternomastoid muscle, which is the big muscle in your neck. And then when those are wasted up, then you're relying on these types of muscles like your fingers to try and stabilize your whole right side, because he's totally dependent on getting air into the right side. So he's using his fingers and his knuckles against the street to try and crank up the right side of his chest. This is his only way to try and get air to get into the right lung.
You know, Doctor, showing you what's been marked as State's Exhibit 938. Is this a related series of photographs and images?
Yes.
Your Honor, we offer States Exhibit 938.
Any objection? 938 is received.
So, Doctor, tell us what we see here in Exhibit 938.
The focus would be, I mean, the top panel is the same as the bottom one. The bottom is just a blow up of what you're seeing on the top. And the focus on the left-hand side is his shoulder. And again, as I mentioned, when you have difficulty in breathing, you begin with the diaphragm, the rib cage, you go on to the accessory muscles like the sternomastoid. One of the very last muscles that you will use is your shoulder. You don't really use your shoulder for breathing. But if you look here on the left-hand side, the shoulder is extremely prominent. So this would be what like people in a gym would call sculpting of the shoulder muscles. And you're seeing them standing out very prominently. So at this point on the left-hand side, he's taking a breath in, using his shoulder to try and get a breath in. And then on the right side, you see between a breath where he's relaxing. He's breathing out. And it's the two of them are shown, so as you see the marked effect on the left. But again, you have to realize that the shoulder is a very ineffective way of breathing, because at that stage, the chest is all so expanded. So when you contract your shoulder, because the chest underlying it is so expanded, you get very, very little air in. It's a very poor way of breathing, but it's what you have to do when everything else is failing. When you're in extremis, you will call on the use of the shoulder to try and breathe.
So, Dr. Tobin, have we covered the first item, that is handcuffs on the street?
Yes.
So let's talk about number two, the knee on the neck. Explain why the knee on the neck is so significant.
The knee on the neck is extremely important because it's going to occlude the air getting in through the passageway.
So is it possible, doctor, to perhaps even demonstrate with an anatomy lesson?
Yes.
That may be relevant.
To understand the knee on the neck, you need to examine your own necks, all of you here in the jury, like I'm doing now. And so, I mean, the first thing is if you put your index and thumb up here at the top of your neck, the first big thing you're going to find is your Adam's apple. And you can find the Adam's apple, and it's a very sturdy structure because it's surrounded by cartilage, and it protects the voice box, the larynx, which is essential to for speech. And so any amount of compression on the Adam's apple is not going to compress it. This is an extremely strong, sturdy structure. It's not going to be compressed by a knee on the neck. Then you go down from your Adam's apple and you feel the little bumps beneath that. And these are the rings of cartilage of your trachea or your trachea. So this is your windpipe here. And so that's, again, because of the cartilage there, a knee on the front of that part is not going to cause compression, okay? But then bring your finger up to the top of your Adam's apple. And up at the top of your Adam's apple, you're now directly over the hypopharynx. And the hypopharynx is the crucial area in Mr. Floyd. So this here is where the hypopharynx is located on your surface anatomy.
So why is the hypopharynx important for understanding this case, what happened?
The hypopharynx is very important for understanding this case for a number of reasons, because it's so vulnerable, because it has no cartilage around it. It's going to be an area that is compressed. It's extremely small to breathe through, and it becomes very important for being able to continue to breathe through.
Doctor, I want to show you what's been marked as States Exhibit 935 and 937. Could you identify, just for the record, tell us what's depicted?
Yes,
there?
I'm looking at 937, which is the hypopharynx.
and then 935. There we go. And 935, which
I'm
which is
looking
it?
at 935, which is the hypopharynx with a coin.
And do these two images fairly and accurately depict the hypopharynx?
They do.
Your Honor, all for states exhibit 935 and 937.
935 and 937 are received.
We could show them to the jury. So, Doctor, using exhibits 937 and 935, could you help us to better understand what the hypopharynx is and what it does?
Right. So what you're looking at here, I don't know if this works. Yeah, it does. So here at where I've drawn in red is the top of your tongue. Okay, and that's the tongue there. And then above it is an empty space. And then above that is the top of the hard palate. So that orients you there. And say then the tongue comes down along here. And the critical structure in this case, because the act of speech in Mr. Floyd becomes very important, how he was able to speak and all these different things. So the structure that gives us speech are the vocal cords right here. And they're in the voice box and in the larynx. And then we have a little area here called the epiglottis. It's a little sliver. And that comes back to prevent food going the wrong way when we're swallowing, because we use the hypopharynx both for swallowing, for eating, and we use the hypopharynx for breathing. So when we're breathing, the air is going to come in through your nose or your mouth, go on down through the hypopharynx, then through the vocal cords and into the windpipe, into the trachea, and go on down into the lungs. Whereas when you're swallowing, that trapdoor of the epiglottis will prevent the food going into the air passages and will direct it into the food tube at the back of the esophagus. The area of the hypopharynx then is exactly from the base of the epiglottis, the first yellow arrow, down to the second yellow arrow, which is the larynx. And it's just that little area that is the size of the hypopharynx.
Could we see 935, Brett?
And so we know that the cross-sectional area of the hypopharynx in adult people, I have it here in the millimeters, 199 to 303, which are obviously difficult to remember, those type of millimeters. But in fact, right in the middle of this would be the size of a dime. So a dime is basically the size of what the hypopharynx, and it tells you how small and how vulnerable is this area. So if it's going to be decreased in size, it's a very tiny area.
And so why is the hypopharynx important in the case of Mr. Floyd?
Because the hypopharynx is going to be the area that will be vulnerable to occlusion from the knee on the neck. But in addition, the hypopharynx has another aspect, and that is the hypopharynx is also controlled by the size of your lungs. As your lungs expand, you increase the size of the hypopharynx with every breath. And so there's a regulation of that that's going on.
Was Mr. Chauvin applying force or pressure to the hypopharynx of Mr. Floyd that you observed?
At different times. It varied from time to time.
Now, are you able to tell us if Mr. Chauvin had put his weight directly, his full weight on Mr. Floyd's neck, are you able to tell us what impact or effect that would have had on Mr. Floyd?
Right. If Mr. Officer Chauvin had placed his knee directly on the hypopharynx, just that area of the dime, and it never varied from there, and it kind of came in like a bullseye on that particular area, then you would expect that this area would become totally occluded. But he varied the position. Mr. Floyd varied the position of his head, and Officer Chauvin also varied the position of his knee. So it varied over time.
And if it had become totally occluded, then what?
If it had become totally occluded, within seconds, you were going to drop the level of oxygen to a level that would be produce oxygen deprivation in the body, resulting in either a seizure or a heart attack, one or the other.
Do you have another photograph taken from footage at the scene that would help the jury understand this point?
Yes.
I'm going to show you what's marked as State's Exhibit 941. And this is derived from Exhibit 15 already in evidence. Do you recognize this this photograph in 941?
Yes, I do.
Your Honor, we offer State's Exhibit 941.
Any objection? 941 is received.
Dr. Tobin, tell the ladies and gentlemen of the jury what it is you mean to convey here in Exhibit 941.
So if you're looking, say, on the one at the left, and if you look at me first before you look at that. So if you stick your finger in your ear and you draw a line from the finger of your ear going down through the vertebral bodies in your spinal column, you can get a line going down, and you're looking at that axis. And that's what I've drawn in here with the yellow dotted line. And so if you look here on the first slide, you see that Mr. Floyd's nose, his face, is directly face down on the street. It's not at any angle. So the next thing is, again, don't look at this at the slide. Feel yourself on your own neck. And now if you put your hand at the back of your neck and you feel the bottom of your skull. And so where the bone of the skull ends, and then you come down from that and you'll find, and you put your whole palm of your hand around it. Sorry?
Members of the jury, the witness has asked you to do certain things. These are not required. You may do them, and he should phrase it more in terms of if you were to do that. And if you wish to do it, that is your choice. You are not required to do anything that the witness instructs you to do, but feel free to do it if you wish. Mr. Blackwell.
Thank you, Your Honor. Dr. Tobin, if we could go back to where you're explaining the anatomy and the back of the base of the skull.
Yep. So as I'm putting my hand here at the back of my neck, and I'm feeling the tip of my skull, and then I'm bringing down my hand, I'm feeling an extremely thick ligament, and that's called the nuchal ligament. And it's almost, as I put the full palm of my hand on my nuchal ligament, it's almost like wood. It's so strong a ligament. And that ligament is what you're seeing. The knee is being placed over on the left-hand slide. And so with a knee directly over the nuchal ligament, it can cause no obstruction because this is such a dense ligament. And that's what you're seeing. And you're seeing as well with the yellow triangle, the yellow diagonal here, that the bulk of Officer Chauvin's knee is above that yellow line. The second thing, separate from this, on this slide, you can see that Mr. Floyd has his face rammed in to the street because he's using his face here to try and crank up his chest. He's actually using his forehead and his nose and his chin as a way of trying to help him get air into the right side of his chest. There's another way to crank up his chest.
And how do you contrast that to what we see in the photograph on the right in Exhibit 941?
On the right-hand side, you can see now the orientation of Mr. Floyd has changed. And also you can see the position of Officer Chauvin's knee has changed because it's come down below the yellow diagonal. And in this position, there's going to be far greater compression of the hypopharynx in this region here compared with what you were seeing on the left side. On the left side, there's no compression of the hypopharynx, but on the right side, and if you watch the videos over time, you will see that there is a variation over time as to where exactly is the location of Mr. Floyd's head and where is the location of Officer Chauvin's knee.
And in the photograph on the right, the knee is exerting, Dr. Tobin, greater force on the hypopharynx.
Correct.
Is it possible to calculate the amount of force?
Yes, it is. So we can calculate the amount of force based on the weight of Officer Chauvin, on his body weight, taking into account how much gear weight, the gear that he carries. And then also you have to remove out the weight of his shin bone and his boot. And so subtracting out all of these, and then you can calculate the weight.
Can you also calculate changes or narrowing in the space that people have to breathe through?
Yes, you can, separately.
Would this be in any way akin to breathing through a small opening like a straw?
Yes, it would. So, I mean, when you have to breathe through a narrow passageway, it's like breathing through a drinking straw, but it's much worse than that, because breathing through a drinking straw, I mean, is somewhat unpleasant, but not that unpleasant. And then it gets much worse than that.
So as the space narrows, is it more difficult than to breathe through?
Enormously more difficult, and we know that from physics.
And through physics, then, is that something that can also be calculated?
Yes, that can also be calculated.
And that type of a calculation, would it be specific per se to George Floyd?
No, it wouldn't. This would be for anybody. For we know in terms of what happens physiologically when you have this level of narrowing, this is going to happen to everybody.
Can you please explain to the jury what those calculations would show about the effect of the narrowing on the airway on breathing?
Right, yes. I believe there's an exhibit that relates to that.
Let me then show you what's marked as States Exhibit 940 and 939. Yes, sir.
Have you offered those, Mr. Blackwell?
Yes, I do offer those.
Any objection? (939) and 940 are received.
So let's start with Exhibit 940. Dr. Tobin, tell us what's depicted here. Describe this for us.
Yep. So this is a physiology experiment. And what it's looking at is what is the effort to breathe. That's what's shown along the y-axis of the plot. And then it is with different levels of narrowing. And so the very bottom one with the white triangles, the lowest curve, that's normal. There is no narrowing. And so we see that as the flow varies, and shown in red is what would be the normal flow rate in a 46-year-old man. And we can see what is the work that is done. If you look at the normal one, and then you look at 60% airway narrowing, and this is much more narrow than breathing through a straw. And you can see there's really no bigger increase in the effort to breathe. It's hardly different from what it in terms of normal. But then if you get 85% narrowing, now you see that the effort to breathe increases 7.5 times compared with what it was with no narrowing. And so you're seeing a huge increase in the work that is required. It becomes far more difficult to breathe as the narrowing becomes more narrow.
And doctors, let's look at Exhibit 939.
So this is the science behind that plot before I showed you. And this is just the equation in physics that tells you how that works. And the key thing when you look at an equation like this, for me as a physiologist, is I focus on the square sign of the stricture. That tells me here when I see a square sign on top of it, and it is below the level on the equation, it is the denominator. I know with that you're going to be fine all along for a period of time, and then suddenly everything is going to increase enormously. You're going into what we call an exponential increase. And that's exactly what we see on the experiment that was done, where we're seeing there's really nothing happening at 60. It's nothing much. But then at 85%, it suddenly takes off. And if you had beyond 85%, it would be even more and more. And so based on the formula here, you can tell that as you're narrowing and narrowing, the effort to breathe is going to become extraordinarily high and at some stage unsustainable. You're just not going to be able to do it.
So in this case, in the case of Mr. Floyd, the narrowing was of his hypopharynx?
It was in the hypopharynx, yes.
Did the Mr. Chauvin's knee on the neck then cause the narrowing of the hypopharynx?
Yes, it did.
So given the changes that you observed in Mr. Chauvin's knee on Mr. Floyd over time, were any of those changes significant from the standpoint of placing pressure on the hypopharynx?
Yes, they're extremely significant.
Let's look, Brett, at Exhibit 947. And Your Honor, we'd offer Exhibit 947, which is taken from Exhibit 15.
Any objection? 947 is received.
Now tell us what we see here in Exhibit 947.
What you're seeing is the orientation of Officer Chauvin. His body build is quite erect here, but in particular, what you're seeing is that the toe of his boot is no longer touching the ground. This means that all of his body weight is being directed down at Mr. Floyd's neck. Because in many of the calculations, I excluded the effect of his leg and his shoe because some of it was touching the ground, but here you can see none of it is touching the ground. So we're taking half his body weight plus the weight of his half the gear, and all of that is coming directly down on Mr. Floyd's neck.
I want to show you what's marked as Exhibit 943. Did you assist in preparing this exhibit?
Yes, I did.
Would it help you in explaining your testimony?
Yes.
Your Honor, we offer Exhibit 943.
Any objection?
Murder.
943 is received.
And Your Honor, if Your Honor could clear the screen. Thank you, John. So Dr. Tobin, what do we see here in Exhibit 943?
What we're seeing is that half of his body weight plus half his gear weight is coming down. That's 91.5 pounds is coming down directly on Mr. Floyd's neck.
Is that all we see?
And the reason we're seeing that is because the toe is off the ground and there is no body weight sitting back. He's not hunkering back on his heels. So everything is directed down on his knee. In this place, his shin and his toe and his boot is playing no contribution.
And were there times also when Mr. Chauvin's left knee was on the back of Mr. Floyd's neck?
Correct.
And when was that?
When his knee is on the back, that's a separate set of forces. It's the same force, but it's compressing a different area. It's compressing inside his chest.
And what about the time when Mr. Floyd would have had his face smashed directly into the pavement?
When his face is into the pavement, at that time, like one of the ones I showed you, if it's coming down on the nuchal ligament, it's going to be a huge weight for Mr. Floyd to try and breathe, but he won't be compressing the hypopharynx at the time when that's happening. So all of these different forces they're somewhat complex in terms of how they're interacting, but they're all coming to the same point.
Now, you paid particular attention, you told us, to the first 5 minutes and 3 seconds of the subdual on the ground.
Yes.
How would you characterize Mr. Floyd's oxygen levels during the first 5 minutes and 3 minutes that Mr. Chauvin was on top of him?
We know that his oxygen levels were enough to keep his brain alive. And the reason we know that is because he continued to speak over that time. We know that he made various vocal sounds for 4 minutes, 51 seconds from the time that the knee is placed on the neck. And that's telling us partly that he's speaking, but the big thing is it's telling us because you can't speak without a brain being active. And so we know there's oxygen getting to his brain for whenever he is making an attempt to speak.
And Mr. Blackwell, just anytime within the next 10 minutes, that's a good breaking point. Please let the court know.
Your Honor, this would probably be a good time.
All right, let's take our 20-minute mid-morning break. Just a reminder, doctor, you're still under oath.
Okay.
Thank you.
And I take off the mask.
Please,
You have a seat now.
you may.
Doctor, turning your attention back to Exhibit 943 and focusing on the restraint on the ground.
Yes.
You were focused on the first 5 minutes and 3 seconds, in particular, that Mr. Chauvin was applying his weight to Mr. Floyd's neck.
Correct.
And why was the time period after the first 5 minutes and 3 seconds less significant to you?
Because at that point where he extended his leg, that we see happening, at the point we see that happening is at 24:21. That is when he has suffered brain injury. We see, and we can tell from the movement of his leg, that the level of oxygen in his brain has caused what we call a myoclonic seizure type activity. They're just medical terms, but basically it means that he has kicked out his leg in an extension form, that he has straightened out his leg. And that is something we see as clinicians in patients when they suffer brain injury as a result of a low level of oxygen.
We'll talk about that more in a moment, Dr. Tobin. But is it significant to you whether Mr. Chauvin moved his knee off of Mr. Floyd's neck after Mr. Floyd was unconscious?
No, the movement happens around at different times, but obviously the key thing is everything up to the time that we see the hypoxia, the brain injury that's occurring, and where Officer Chauvin moved his knee after that really is not going to have a material impact on the case.
Would you help the ladies and gentlemen of the jury understand that if Mr. Chauvin is applying pressure on the side of the neck, as we see here in Exhibit 943, how does that translate into narrowing of the hypopharynx?
It's going to depend on what is the orientation of Officer Chauvin's body, what is the orientation of his leg, and then also in particular into what is the orientation of Mr. Floyd. Where exactly is the orientation of Mr. Floyd's head? Because if it's the nuchal ligament is underneath Officer Chauvin's knee, there's going to be very little compression of the hypopharynx in this region. Then if it moves to the side and Officer Chauvin's weight is coming down on the side of Mr. Floyd's neck, then you're going to get huge compression of the hypopharynx.
And again, looking at Exhibit 943 and focusing on the first 5 minutes, was his knee overarchingly on the side, or was it on the back of the neck?
For the first 5 minutes, the left knee is on the neck virtually all of the time. The right knee, by my calculation, the right knee is on his back 57% of the time. The reason I can't say that it's on 100% is for the most of that other time, I don't get a good view. The cameras move around, it's the body cameras, and so I can't see it. But for that period of time, the crucial period of time of the 5 minutes and 3 seconds, I can see Officer Chauvin's knee on his back for over 57% of the time.
Let's talk about the third mechanism, the prone position. Would the fact of Mr. Floyd being placed in the prone position also had an impact on the narrowing of the hypopharynx?
Yes, placing him on the prone position has several different effects, but particularly it also causes narrowing of the hypopharynx, among other things that the prone position does.
Is there a concept in physiology referred to as lung volumes?
Yes, there are.
What is that? What does that refer to?
That's just the way that we lung specialists, we measure how big is the size of the lung in different patients, and we quantify out in different areas, what level of the lung there is, whether it is different segments of the lung behave in different ways.
Do you have an illustration you brought to help us better understand this concept?
Yes, I have.
I'm going to show you what is marked as Exhibit 929 and have you first just identify it.
Yes, I identify 929.
What is it?
This is it shows you lung function and it shows you tidal volume.
And is it an accurate illustration of
Yes, it is.
lung function and tidal volume?
Yes, it is.
Your Honor, I offer Exhibit 929.
Any objection? 929 is received.
All right, so if we could start at the beginning of it, Mr. Auntie.
So do I go ahead and describe?
Yes, would you please?
Yep.
Hold on.
Oh.
Also, let's not talk
For each other, we're getting into that bad habit. So
Right.
if you could ask the question again, Mr. Blackwell, I forgot.
Thank you, Your Honor. I'm just going to ask you, Dr. Tobin, if you would explain to us what we see in Exhibit 929.
Yes. We're looking here at the lung inside the chest. The chest is in gray, and then we see the lung inside it, and surrounding it is the pleural space. And we're seeing that as you were looking at breath going in and out, it generates a tidal volume. The tidal volume is shown as a waveform down at the bottom. And so that's what happens in somebody with regular breathing.
All right, let's see if we can get our tidal volumes to tide.
So here you can see that the chest is expanding. Like on the front, you're seeing the pump handle action of the chest. And then with each breath, you can see air going into the lung, and that produces the tidal breath. So this is the tidal volume. And then on exhalation, it's going back out.
Dr. Tobin, is there a standard or normal size of breath?
Yes, there is. In virtually all adult people, it's about 400 cc's is the size of a tidal volume.
Same for men and women?
Same for men and women, and it's the same for teenagers and grandparents.
So can lung volumes be calculated?
Yes, then you can calculate all further additional lung volumes in addition.
Did you actually do a calculation for Mr. Floyd's lung volume?
Yes, I calculated out his lung volumes precisely based on his age, his sex, and his height.
I want to show you what's marked as Exhibit 939 and tell me if this reflects your calculation.
Yes.
I said 939 is 930, Exhibit 930. So would using this be helpful to explain your testimony?
Yes, it would.
So, Your Honor, I want to offer Exhibit 930.
Any objection? 930 is received.
Okay, so these are the lung volumes in Mr. Floyd while he's sitting on the sidewalk. And the key lung volume that we're going to be focusing on is the EELV. That's the end expiratory lung volume. And that becomes crucially important in understanding what happened to Mr. Floyd. And I calculate out his EELV to be 3,840. And that's what it's shown there by the horizontal purple line. Sitting on top of that then is the size of each breath. And then underneath the purple area is the residual volume. The residual volume is when you blow all the air out of your lung, and after you're finished blowing, you can't blow any more out. That's the air that's still left inside your chest, is the residual volume. And that in Mr. Floyd is 2 liters and 300 cc's, 2300. That's included in the ELV. The ELV is everything below that horizontal purple line. So the ELV sitting upright is 380, 3840. We also see on
So,
this
Doctor,
slide,
if I could stop you for just 1 second, and to help us understand better the end expiratory lung volume, the EELV, would that be commonly referred to as oxygen reserves?
that it's also where your main oxygen stores are in the body, are contained within your EELV. This is where you store your oxygen reserves.
So for the ladies and gentlemen of the jury, it's true that not all the air you breathe in is exhaled out.
No. Yes. I mean, because the ELV is basically the volume that's in your lung in between each breath. So when you are breathing in and out, when you're between the next breath, what's in your lung is your EELV.
And the residual volume, the RV, is that also residual oxygen that the body can use?
Yes. So the oxygen reserves you have are included in the EELV, and obviously a subset of the EELV is the residual volume. So all below the purple horizontal, all below your tidal volume is your oxygen reserves.
And so then can you explain your calculations for Mr. Floyd's lungs?
So here we see, based on his age, his sex, and his height, we're seeing exactly that his ELV sitting upright is 3,840, and we see his residual volume is 2,300.
And again, the amount of air he's taking in tidal volume would be the same as anyone else.
Right, and that's the 400 up at the top, the pink piece going up and down. That's the tidal volume, and that's the same as for anybody.
And 400 cc's?
Correct.
Is that cubic centimeters?
That's cubic centimeters, correct, or milliliters, or however you want to put it.
And the oxygen graph that's on the side,
Yes.
what does that depict?
So the level of oxygen in anybody varies with age, and this is exactly the level of oxygen you expect in a 46-year-old man. So it's a PO2, that's the level of oxygen measured, and pressure of oxygen. If you were to do an arterial blood gas where somebody stuck a needle into your wrist, took out a sample of arterial blood, that is the level of oxygen they'll find, 89 millimeters of mercury is the units we use when we describe levels of oxygen.
Now, you told us that Mr. Floyd, being in the prone position, served to narrow the hypopharynx or decrease the volume of oxygen in the lungs.
Right. It had multiple effects, including those two.
Why is that?
Because the ELV is very important in terms of, obviously, it's where we store the oxygen, but as well as that, it has an effect on the upper airway. So when you breathe in, you don't notice it. As you're expanding your lungs, you're aware of expanding your lungs, but at the same time, the size of your hypopharynx also widens out because there's attraction forces that are occurring between it. It's just part of normal breathing that you, as you inhale, you expand your lungs, but you also expand that little area that you have, the air has to go down through. And so that is influenced by the size of the ELV. Likewise, when the ELV gets less, then the size of the opening of the hypopharynx will also get less. It's going to collapse down as your ELV goes down.
Did you actually calculate the reduction in lung volume for Mr. Floyd due to the prone position?
Yes, I did.
Brett, could I show Dr. Tobin Exhibit 927? Doctor, is Exhibit 927 the calculation that I'm referring to?
Yes.
Your Honor, I offer Exhibit 927.
Any objection?
Yes. Yeah.
927 is received.
So, Dr. Tobin, Tell us what we're seeing here in Exhibit 927 as relates to Mr. Floyd in the prone position.
You're seeing a drop in his end peripheral lung volume. It's smaller when you're placed face down. And so you're getting a decrease in the end peripheral lung volume, and that's occurring because, in part, say you're lying flat in the bed with your face into the pillow. If you're lying prone, face down, you're no longer going to be able to use your bucket handle action. So your lungs are going to get smaller. You're also going to have greater difficulty in using your bucket handle action. It's less so than the pump handle. And then, as well as that, as you lay face down, your belly is going to rise up into your chest. And so your diaphragm rises. So the lungs get smaller, and that is what we see here. So in anybody who is turned prone, you see that the lung volumes will on average go down by about 24% by simply turning them prone. So with that, when you're getting the smaller lung volumes, you're getting less reserves, and you're also going to affect the hypopharynx.
So if the lung size goes down 24%, do the oxygen stores also go down 24%?
The oxygen stores will go down by 24% as well. Once you have less volume inside your lungs, your oxygen reserves are going to go down proportionally.
Is it absolutely 24%?
No, I mean, again, in physiology, the way we do things is we look at what is the average change that happens when we do experiments. But in biology, there's always a certain amount of biological variation. And so there's always going to be something like a 2 to 4% variation that you're going to see around these numbers. But when we speak about something, we speak in terms of the average change that is occurring.
So is a 24% reduction significant in the case of Mr. Floyd?
Yes, it's extremely important because, again, because of the factors that we're dealing with. We're seeing here that with the reduction in the ELV from the prone, we're decreasing the oxygen reserves. We're also affecting the size of the opening of the hypopharynx, because as the ELV goes down, you're getting a proportional reduction in the size of that. And in addition, when you're turned prone like this, your work of breathing goes up because the stiffness of your lungs changes and the stiffness of your chest wall changes. So the person has to do more effort to breathe in that position.
So the hypopharynx is linked to the size of the lung, that is the size of the hypopharynx.
Yes.
So doctor, maybe you can help us to understand this. Is it true that some persons suffering from COVID are actually treated in the prone position?
Absolutely.
Why is that?
It's a different scenario, but I mean, in any patients with pneumonia, and particularly with COVID, but we see it in any patients with pneumonia, when you turn them prone, it can help. The problem is if they have pneumonia, they have bad matching between the blood vessels going through the lungs and the air sacs. We saw the movie at the beginning where you saw the alveoli and you saw all those blood vessels surrounding the bunch of grapes. In people who have pneumonia, COVID, whatever, that matching is going to be very bad. And that's what leads to the worse oxygenation in those patients. If you flip those patients prone, some of them will show no improvement, but a substantial number of them, the matching will get better between the blood vessels and the air sacs. You can't predict ahead of time until you turn the patient prone. You're not going to know which ones are going to do better, but some of them do. And so this is why prone has been very valuable in patients with COVID, but that is in people with pneumonia. This does not apply to people with normal lungs. It's not happening.
So Dr. Tobin, also a lot of people sleep in the prone position.
Yes.
Is that dangerous?
No, because again, for the average person, you have so much reserves. So I mean, for a drop of 24% for you, it's not going to have any impact because you have a huge amount of reserve. It's not going to matter. But if you have somebody who drops the lung volume by 24%, and then that person is going to have to cope with the knee on the neck, and is going to have to cope with having the arms pushed up and being unable to move the left lung. Then it's a whole different kettle of fish.
Thank you, doctor. So have we covered the third mechanism, the prone position?
Yes.
Then let's talk about the fourth one, which is the knee on the back, arm, or side.
Yes.
Now, if we bring to mind Mr. Chauvin's right knee on Mr. Floyd's back or left side, well, let me ask this, forget that question. Does it matter whether the right knee was on Mr. Floyd's back or left arm or his side?
No, it's really all amounting to the same, because we're talking again back to the bucket handle and the pump handle. So whether it's on the back or rammed in against the side and down on the arm, all of these are just going to markedly impair your ability to be able to move your chest with your bucket handle and your pump handle. You just can't do it. It's all rammed in. And what you have to, the whole time in this case, you have to constantly keep in mind that this is taking place on the street. The street is playing a huge part because it's coming in the front and totally preventing every action happening on the front.
And did that influence then Mr. Floyd's oxygen stores or reserves, the EELV?
Right, yes, they're going down. As a result of once the ELV goes down, every proportional decrease you're seeing in the ELV, you're seeing the same proportional decrease in the oxygen stores.
And were you able to calculate what that influence was?
Yes.
I want to show you what's marked as Exhibit 932. And I ask you, Dr. Tobin, does this reflect the calculations that you did?
Yes, this does. So now you see with the effect.
One moment,
I'm
Doctor.
sorry.
One moment.
Going off.
Your Honor,
I apologize.
I offer Exhibit 932.
Any objection? 932 is received.
Now, Doctor, please tell us what we see here in 932.
So what you're seeing here now is that now it's no longer just prone. Now you have the knee on the back in addition, or the knee on the side. And so this is going to further compress down the ELV. And so here you're seeing that the ELV has now been really squashed down. So it's by the combination of turning him prone and also having the knee on the back, you're seeing a 43% reduction in the ELV, which means that there's also a 43% reduction in his oxygen reserves, which means there is also a huge reduction in the size of the hypopharynx, because this is directly linked to the hypopharynx, and you will see how this is linked. And so when you decrease the size of the ELV, that's going to cause it. And then an additional effect is that your work of breathing goes up. Because when he has to try and fight with the small volume, he has to try and fight with the small volumes that he has, and then he has to try and lift up the officer's knee with each breath. And also remember, he has to try and also lift up the effect of the other officer pumping in his arm with the handcuffed arm. They're pushing it into his chest. So he has to make all these efforts to try and breathe against that.
So, doctor, when you tell us about a 43% reduction 24% of that is just being in the prone position.
Correct?
And the other 19% then is the contribution of the knee on the neck and back.
Yeah, exactly. The other 19% is, so 24% from being prone, another 19% coming from the knee on the back.
And just so we're clear for the jury, how does this again translate into difficulty in breathing?
So again, I did calculations of this, and basically you're looking at more than a threefold increase in the work of breathing in terms of just from the effect of nothing else. That's even leaving out the effect of the knee on the neck, just from looking at what's happening within the chest. So there's a huge increase in the work that Mr. Floyd was performing just to try and cope with what was happening below the neck, leaving aside what is happening above the neck.
Doctor, I want to show you exhibits 922 through 926. And after you have a chance to see them, I want you first just to identify just what you're seeing in those before we show it to the jury.
Yes, I identify.
Tell us, please, what it is for the record.
We're looking at the effect of the lungs on the hypopharynx, beginning with Mr. Floyd sitting on the sidewalk.
Your Honor, we offer exhibits 922 through 926.
Any objection? Nine 22 through 926 inclusive are received.
So, Doctor, if you will walk us through these to help us to understand the narrowing of the hypopharynx in the case of Mr. Floyd.
Right. Before you look at the hypopharynx, just look down at the lungs, and you see that the lungs, as you would expect, are expanding with each breath. You see the diaphragm going down. You can see the pump handle action. The lungs are getting bigger front to back. But then you see that exactly as the lungs are expanding, if you focus up in the yellow boxed area, and then the yellow boxed area is enlarged over on the right side. And you can see that as you inspire, the size of the hypopharynx is also enlarging. So you're seeing both of these happening. So it's the effect of the lung volume, how it influences the opening of the hypopharynx. And this is sitting on the sidewalk.
So looking at exhibit 922, what do we see here now in the prone position?
Right, so now we see Mr. Floyd after he's turned prone, and now we can see the lungs are smaller than they were because they fall. We know when you turn prone. And then you also see now that the area, the hypopharynx, is further narrowed because the lungs, as they get smaller, they have less effect in keeping that open. And so that gets smaller.
Okay.
And then we have the knee on the back. And now we see with the knee on the back, then the lungs become further reduced, like I showed you for the precise calculations of the volumes. And now you see here is the size of the hypopharynx further is shrunk as a result of it. So the opening through the hypopharynx is impacted by the knee on the back.
And if we compare them all together, all three,
Right.
exhibit
So
9.
here you're seeing them all together. So on the left is sitting on the sidewalk, then just the effect of prone, and then the effect of prone with the back compression. And you can see the arrow is pointing out to you on the first one, where is the hypopharynx, right, that area, and with the epiglottis directly in front of it. And you can see that it's expanding when he's sitting down. And then when he's prone, and when he is prone with the back compression, you're seeing that the area that of expansion is getting smaller, as exactly as what you would expect to happen.
Going back to Mr. Floyd's lung volumes, Dr. Tobin, is there a point in time when you determined that Mr. Floyd did not have enough oxygen in his stores even to remain conscious?
Yes, there is.
And when was that?
The time in terms of the loss of consciousness was 24:53. We can tell it precisely in terms of where the absence of consciousness occurs.
And can you tell by facial features or
You
anything?
can tell, because I mean, this is something I do not as a physiologist, but as an ICU doctor. I mean, we're always looking at facial features to be able to tell how conscious somebody is. And we can tell by how you flick your eyes or how you move the muscles in your face, and that you'll be able to tell, is the person conscious or unconscious? It's a very important sign in patients as we're taking care of them, to be able to monitor that. And the primary way we monitor it is by inspecting it. So I would have done this millions of times.
And do you know, Dr. Tobin, what his oxygen level would have been at the time he went unconscious?
Yes, we also know that at the time, if you have somebody who is in the situation who is at risk of trouble with oxygen, we know that the moment at which you lose consciousness, the level of oxygen in your blood will be 36. That's the number that's associated based on very hard scientific data telling us that.
And again, the normal level of oxygen was
In Mr. Floyd was 89 for him. In a 46-year-old man, you expected the normal level of oxygen is 89. The level at which you will have an absence of consciousness then will be 36.
Doctor, I want to show you Exhibit 928. If we could clear the screen, Your Honor. And first, for the record, before we show this to the jury, can you just identify what is Exhibit 928?
We're looking at the effects on Mr. Floyd's oxygen as a result of all the various maneuvers that are being done to him.
Your Honor, I offer Exhibit 928.
Any objection? 928 is received.
So tell us, Dr. Tobin, what do we see here in Exhibit 928?
We're looking at, I mean, when it began, the level of oxygen, when I saw it, began with a level of oxygen of 89, and then we see that it falls down to 36. The slide is looking a bit different than what I saw before. Yeah, so here you see that the level of oxygen beforehand, it's 89. And then at the point when we notice the lack of consciousness in his face, that the level of oxygen will drop down to 36.
One more answer.
And so that tells us there, it tells us the time for the loss of consciousness. And then we know that it continues from there, and where from the time that he stops breathing, which is 25:16, and then I calculated out that from there on, that you can calculate based on, again, very rigorous science, when the level of oxygen will have gone down to 0. But this first one, we're looking at the loss of consciousness at 36. And that's happening at 20:24:53. And we're able to tell that by looking at his face.
And 20:24:53 is 8:24 p.m. and 53 seconds.
Correct.
Was there a point in time when Mr. Floyd no longer had any oxygen left in his body?
There is, because again, once he stops breathing at 20:25:16, then it would take another 25 seconds for the level of oxygen to go down to 0. At that point, he wouldn't have an ounce of oxygen left in his entire body.
Doctor, I want to show you Exhibit 931.
Okay.
And ask you first if you would just tell us what it depicts before we show it to the jury.
Yes, that's it, showing exactly
What do we see in 931?
So what we're seeing in 931 is that his level of oxygen has gone all the way down to 0.
So we're going to show this to the jury, but first let me move to admit Exhibit 931.
Any objection? 931 is received.
Now, Dr. Tobin, would you explain to the jury what we see here in Exhibit 931?
We're seeing that the level of oxygen has gone down to 0, that there is, at that point, there's not an ounce of oxygen left in his body. And again, this is totally, you can figure this out with very precise science, looking at once somebody stops breathing, what will be the rate of decline in the level of oxygen, how long it will take to reach 0. And this is, so we see here that he reaches a level of 0 of oxygen at 20, 25, 41. And so at that point, there's not an ounce of oxygen left in his body, in his entire body at 20, 25, 41.
And so was the knee then lifted off of his neck at the point there was no more oxygen in his body?
No, the knee remained on the neck for another 3 minutes and 2 seconds after we reached the point where there was not 1 ounce of oxygen left in the body.
Thank you, doctor. Are you aware of studies suggesting that putting someone in the prone position and putting a weight on the back is not dangerous?
Yes, I'm aware of these studies. They largely come out from San Diego, from the group of Dr. Chan and Vilke and his colleagues.
Are you able to generally characterize the nature of these studies for the jury?
The bottom line is they're highly misleading.
Are they relevant to the analysis you've just given to the jury this morning?
No, they're not relevant to the analysis we gone through this morning.
Help us to understand why.
Okay. The problem is in these particular studies, and there's, I mean, I don't know how many in total, but could be close to 10 of them, and where they take people, first of all, they take perfectly healthy volunteers, they bring them into the physiology lab, and they lay them flat and they put a mat underneath them, which is different than the street. And then they measure, they put weights on top of them, so that weights could be lead weight in bags, or else in many of them, they use kind of the barbells that you see in a gym, like an Olympic wheel that you'd see in a gym for weightlifting. And they place those on the back of the subjects, and then they measure various lung volumes. So typically they'll measure what we call vital capacity or maximum voluntary ventilation. These are specific types of lung function tests that you don't need to bother with, but they're showing a decrease in lung availability of around 35%. That's a substantial decrease in your lung volumes that you're finding. And then they conclude in virtually all of their studies that that level of decrease in lung volume doesn't matter because there's no change in the level of oxygen. And so therefore it's not clinically relevant. The problem is in doing a study like that, oxygen is the exact wrong yardstick to be using in a study like this. What they needed to do is continue to measure out the changes in lung volume like the ELV, showing what happens to this. Oxygen will only fall at the very end. It's an extremely insensitive measure. It's very important, but it's very insensitive to know if stuff is going bad inside the body. It's going to be a very late event. And so for their concluding of this.
Let's have another question.
I didn't
Question,
hear the
please.
objection, Your Honor. Should I interpose another question? Please. Right, Your Honor. So to help us to better understand Dr. Tobin, are these studies measuring the diminution or decrease in the oxygen reserve, the EELV?
No, they're not.
I want to show you what's marked as Exhibit 948. And it does Exhibit 948 point to one of the studies that you were referring to?
Yes, it does.
Would it be helpful to use this slide to explain your testimony?
Yes, it would.
Your Honor, we would offer Exhibit 948.
Any objection? 948 is received.
So looking here at this slide, Dr. Tobin, what does this tell us in terms of, for example, the surface area that's involved of the weight on the back?
So if you look at the subject's back, you can see here that there are 4 weights out of a gym that are placed on the back of the subject. And the big wheel out of the plate, out of an Olympic plate, is going to have a diameter of 17.5 inches. And so you can measure the cross-sectional area of that is going to be 240 square inches. The trouble is that when officers kneel on the back of a suspect, they don't place an Olympic wheel on their back, they place their knee. And so the cross-sectional area of the knee is 24 square inches, which is 1/10 of the area of the big bell that you're looking at here. And so we know from simple physics that pressure is force over area. So that's 240 divided by 24. That tells you that the pressure being exerted on the back is 10 times more than what the San Diego people are claiming. They're off by a factor of 10.
So the pressure then being exerted by a knee is 10 times greater, is what you're saying.
Is 10 times greater than is going to be affected by the bell here that's shown from out of the gym, the bar that you're living.
Do any of these studies, doctor, involve a knee on the neck?
Nobody has done any studies involving the knee on the neck. I suspect you'd have major trouble getting that through the ethics committee in any medical school.
Do any of these studies go on for 9 minutes and 29 seconds?
No, they're all very brief studies.
So, doctor, have we now covered the 4 mechanisms that resulted in Mr. Floyd's shallow breathing and the reduction of the hypopharynx?
Yes, we have.
Now, Dr. Tobin, were or are you aware that Mr. Floyd had some pre-existing health conditions?
Yes, I am.
And how are you aware of that?
I mean, I read them in the records from Henneman County, and obviously also saw them mentioned in the autopsy.
Do you have an opinion to a reasonable degree of medical certainty as to whether a person who had none of those pre-existing health conditions, a healthy person, would have died under the same circumstances as Mr. Floyd?
Yes, a healthy person subjected to what Mr. Floyd was subjected to would have died as a result of what he was subjected to.
Are you also aware that Mr. Floyd was found to have a type of tumor known as a paraganglioma?
Yes, I am.
And for the ladies and gentlemen of the jury, what is a paraganglioma?
A paraganglioma is a type of a tumor that is found in the paraganglions, kind of sometimes in the pelvis. And
Is the finding of a paraganglioma significant to you as relates to Mr. Floyd and his death?
no, because one of the key things about a paraganglioma is that it's called the 10% tumor, which means that 10% of people who have a paraganglioma secrete adrenaline. Well, that could be important, but 90% of them don't secrete adrenaline. So you don't, 9 out of 10 at the times that you have a paraganglioma, you have no increase in the amount of adrenaline.
So if somebody were to die from a tumor from some effect of a paraganglioma, would it be a sudden death?
Yes, there's been 6 reported cases of people who have had paragangliomas who have died suddenly. But that's the total in the literature, 6. And those people who died have headaches. And Mr. Floyd complained of a lot of pain in lots of different regions while he's down on the street, but he did not complain of headaches.
So in terms of reported cases where people have died from paragangliomas over the entire world, you know of 6 reported cases.
Yes,
And all of those are sudden deaths.
correct.
Did Mr. Floyd die a sudden death?
No.
I want to talk to you about a different subject. The jurors may have heard one of the officers say, if you can speak, you can breathe.
Yes,
Is that a true statement?
it's a true statement, but it gives you an enormous false sense of security. certainly at the moment that you are speaking, you are breathing, but it doesn't tell you that you're going to be breathing 5 seconds later.
So let's talk about kind of why this is significant. So could you tell us about something that may seem obvious? That is, what's required for speaking?
Right. So, I mean, for speaking, you only speak when you're exhaling. You have to blow air out, and then you vibrate the vocal cords. And that's all there is to speech. So it's air going across the vocal cords, they vibrate, and you speak. But to speak, there's two things important. One is you cannot blow air out if you didn't take a breath in beforehand. So you must have had an inspiration in to speak. The second thing is you cannot speak if your brain is not alert. Okay, so when you see somebody speaking, you know they have had an inspiration momentarily before they're speaking, and that there is oxygen going to the brain at the time that they are speaking.
And by inspiration, you mean that it had to take a breath in directly before
Right.
they're speaking.
Yeah.
Was the timing of Mr. Floyd's speech during the restraint important to your analysis?
Yes, it was.
Why so?
Because it tells us that for the time that he's speaking, and he continues to speak for 4 minutes 51 seconds from the time the knee is placed on his neck, it tells us that there could not have been complete compression, could not have been total occlusion of the neck at that time, for that time, because he's continuing to speak for 4 minutes 51 seconds.
Dr. Tobin, is the brain sensitive to oxygen deprivation?
The brain is the most sensitive area to needing oxygen.
So what percentage is the brain of body weight, and how much oxygen does it consume?
So the brain is relatively small. It's only 2% of our body weight, but it takes in 20% of all the oxygen that we take in. So the brain eats up oxygen at 10 times the normal level. It needs a huge amount of oxygen because it's sending out millions of nerve signals every second. So it needs a very high supply of oxygen.
Then how long can the brain go without oxygen?
That's well worked out. If you stop the flow of oxygen to the brain, you lose consciousness in 8 seconds.
So if you might recall Mr. Floyd's last words, I can't breathe.
Right?
Are those words significant to you as a pulmonologist?
Yes, I mean, obviously they're important different ways. One, he's complaining to you of difficulty with breathing, but they're also telling me that at that time when he's saying, please, I can't breathe, we know at that point he has oxygen in his brain. And again, it's a perfect example of how it gives you a huge false sense of security, because very shortly after that, we're going to see that he has a major loss of oxygen in the way that he moves his leg. And so it tells you how dangerous is the concept of if you can breathe, or if you can speak, you can breathe. Yes, that is true on the surface, but highly misleading. A very dangerous mantra to have out there.
So that if I'm hearing you correctly, when he says I can't breathe, that shows his brain is alert.
Yes,
But then immediately thereafter, his brain wasn't.
correct.
And did you see, or is there anything in the video that you can show the jurors that they can see also that would point to the fact that his brain was no longer alert?
Yes.
Let me pull up Exhibit 47, already in evidence at 2024. So I'm going to play a clip for you, Dr. Tobin, and then tell the jurors what they see afterwards.
Yes. So there's a key finding that you're seeing here, and that is when you see his leg going up. And you have to keep in mind he's prone, so he's facing down. So this is his leg coming up backwards. And so that's what we call as clinicians, that's an extension movement of the leg. And that is something we see when somebody suffers major brain lack of oxygen. And it tells us at that point he's having what are sometimes called a myoclonic seizure, sometimes called a hypoxic seizure. There's different terms that are used, but really they all amount to saying that you're seeing here fatal injury to the brain from a lack of oxygen.
It's sometimes also called an anoxic seizure.
It has all of these different words. There's a lot of different words that are used, but they all come down to the same thing, that it is that at that point, the brain is responding to the drastically low level of oxygen that's present.
And does the fact of an anoxic seizure reflect damage to the brain?
It indicates severe damage to the brain.
And the reflex that we saw with the legs coming up, is that an involuntary reaction?
It's an involuntary reaction. I mean, there's a lot of different medical terms that we apply to it, but the bottom line is that you're seeing that the leg jumps up like that as a result of a fatally low level of oxygen going to the brain.
So, doctor, we talked about the brain injury. We also told us earlier about low levels of oxygen potentially causing pulseless electrical activity.
Yes.
And is that also then evidence of low oxygen?
Right. So, I mean, when you have a low level of oxygen, that's going to show up in the brain, and it's also going to show up in the heart. And when it shows up in the heart, it's going to cause the heart to beat abnormally. And the particular way that it happened in Mr. Floyd was he developed a particular arrhythmia called a PEA, which is a pulsus electrical activity, where we're seeing there's electricity in the heart, but it's not resulting in any mechanical force. And so that's why it has that name. And so it's the low level of oxygen is producing both. We don't see the PEA, the pulses electrical activity arrhythmia, until that's shown up on the EKG in the ambulance. So it's much later that we see the evidence of it in terms of display. But here we're seeing huge evidence in terms of the leg. The leg is crucial here because this is the time that the first time you're seeing there is major league oxygen damage.
So we reach a point where Mr. Floyd couldn't speak due to low oxygen. Was there any correlation also to a narrowing of the airways that prevented his being able to speak?
Yes, as well.
I want to show you what's marked as exhibits 934, 936, and 933. And just tell us, what are these images in general?
So we're seeing again the same MRI, but at a different view of it that we looked at before.
Your Honor, I offer exhibits 934, 936, and 933.
934, 936, and 933 are received.
So, doctor, tell us what we see here, starting with the first.
Right. So
one.
this is the same MRI that you saw before, but your attention is drawn to by the yellow arrow is the vocal cords, and the vocal cords is simply how you speak. So to speak, you must inhale, you must take air into your lungs, and then when you let the air out, you're going to vibrate those little vocal cords there, and that's what makes the sound of speech. And so here we see the size of the windpipe, the trachea, and this becomes important in terms of speech because our knowledge about the influence of the size of the trachea, of the windpipe for speech, is from patients who had an endotracheal tube in place, and then they developed scarring after that. And so as a result of the scarring, we know what is the point at how much scarring in your windpipe will prevent you from speaking. And so these are just the dimensions. So as you know what is the size of the normal trachea, it's between a quarter and a dime, as you can see here, in terms of the diameters.
And then next slide, Brett.
And here is when those coins have been shrunk to 15%. And even when the trachea has narrowed all the way down to 15%, you are still able to speak. Even when the hole through your windpipe is just this size, as I've shown here, where I've shrunk the size of the coins, you are still able to speak. So it tells you how dangerous it is to think, well, if he can speak, he's doing okay, because at this point, you will be able to speak. But again, if there is a small increase in the amount of narrowing here, not only will you not be able to speak, you won't be able to breathe, you won't be able to live. And so it's a very dangerous thing to think that because you're able to speak, you're doing okay.
And so, doctor, you're not able to speak, breathe, or live once the airway narrows to below 15%.
Correct. Once you go from the 15%, you'll still be able to speak. And then as it gets lower from that, initially you'll be struggling. And then at some stage, you just won't be able to do anything.
Brett, if we could show exhibit 940, it's already invented.
So again, this is exactly, because this is the same experiment I showed you before. And it just so happens, this is pure coincidence. It's at 85%. You're looking at that top curve, and that's the same number that we showed you on the MRI. This is pure coincidence, but you can see here, once you're up at 85%, that the work of breathing is enormous. It's 7.5-fold increase. And then as that narrowing would get further and further, then the work will become unbearable. So again, it just emphasizes at the point where you can't speak and you are in deep trouble.
Doctor, I'd like to transition now from talking about the physiology of breathing to talk about your work as a clinician, taking care of patients with respiratory troubles. Does that experience factor into your opinions today also?
Yes.
Did you do anything to try to understand Mr. Floyd's actual rate of breathing?
Yes, I did.
Why was that important to do?
Because a major part of my work as a lung specialist is looking at people's breathing. You get an awful lot of information by looking at how they breathe, by looking at how they use their chest wall. All of this is extremely informative. And at the lowest level, one of the simplest things to do that is especially informative is simply to count how many breaths somebody takes in. It's one of the vital signs, like with blood pressure, pulse rate, temperature, is the respiratory rate. It's one of the signs that tells us, and it gives us a lot of clues as to what is happening inside the body.
Is this something you've done before?
I've done it millions of times.
Do you train others in how to do
And
it?
I've trained nurses, respiratory therapists, medical students, doctors in how to do it.
And so you're counting the breaths. Do you observe the muscles and things also?
You separately from counting the breaths, you're going to look at the different muscles they're using, whether they're using their sternomastoid, what type of bucket handle action they have, what type of pump handle. You're looking at all of this in a glance. I mean, with somebody as old as me, I can see all of this very rapidly.
So did you take this clinical experience and apply it to your observations of Mr. Floyd's breathing, in this case on the videos?
Yes, I did.
Was there video evidence from which you could take measurements?
Yes, there is.
I want to show exhibit 43 that's already in evidence. So I want to play this, doctor, and afterward tell us what we're seeing. So in a moment it will start.
So if you focus down here on where the handcuff is and where his arm is close to his black shirt is the best place to see. And you can count out his respiratory rate. So you're seeing that he's making a respiratory rate here, then another. And so we need to play it back because
So
I needed to tell you first where to focus. If you focus down there, you will be able to count out the rates.
right, we will play it once more so that you can count the rates so the
Okay.
jurors see what you refer
Yeah,
to.
yeah. 1, 2, 3, 4, 5, 6, 7, 8.
So that was roughly a 17-second clip,
Right?
and you counted 7 or 8 breaths.
Between 7 and 8. Yeah.
And did you use this to calculate a rate of respiration?
Yes, because I mean, it's simple. Once you have 19 seconds and you count out the number of breaths you have here, and if it say you count out 7 breaths, that will come out at a respiratory rate of 22.
Is that number, the respiratory rate of 22, significant to this case?
It's extremely significant
Why is that?
because one of the things in this case is the question of fentanyl. And if fentanyl is having an effect and is causing depression of the respiratory centers, the centers that control breathing, that's going to result in a decrease in the respiratory rate. And it's shown that with fentanyl, you expect a 40% reduction in the respiratory rate. So with fentanyl, his respiratory rate should be down at around 10. Instead of that, it's right in the middle of normal at 22.
So you didn't see a depressed rate of respiration or breathing rate in Mr. Floyd.
No, it's normal.
And so what does it tell you, bottom line, with respect to fentanyl as relates to Mr. Floyd?
Exactly. In terms of fentanyl, one of the major changes you see in fentanyl is a slowing of the respiratory rate. So, and again, we would be expecting a 40% reduction in the respiratory rate with fentanyl. The normal respiratory rate is 17 breaths per minute, plus or minus 5. So that would mean a normal respiratory rate of between 12 and 22. That's the normal range of respiratory rate. And so if it was with fentanyl, you'd be expecting a respiratory rate of 10. Instead of that, you count it here yourself. And you can see when you count it yourself that the respiratory rate is 22. So basically it tells you there isn't fentanyl on board. That is affecting his respiratory centers. It's not having an effect on his respiratory centers.
So Mr. Floyd's respiratory rate was normal at 22 just before he lost consciousness.
Correct.
So the jury may have heard some other information in the case about the fentanyl related to an elevated carbon dioxide level in Mr. Floyd's body in the emergency room. Was that significant to you?
Yes, that's very significant as well.
How so?
Because he's reported to have a PCO2, sorry, I take it back. He's reported to have a carbon dioxide level in the arterial blood in the emergency room of 89. That's a very high level of carbon dioxide. And so you have factors in Mr. Floyd to explain why his carbon dioxide was found at 89 in the emergency room.
So doctor, would you first tell us what would normal have been for carbon dioxide levels?
The normal carbon dioxide level in you or me is 35 to 45 millimeters of mercury. That's the normal. You don't need the millimeters of mercury stuff, but they're the units that are given in the hospital chart.
So you said that there were significant factors in the case of Mr. Floyd. Would you help the jury understand what those were?
Yes, the important factors are that we know that he made his own last spontaneous effort to breathe at 20:25:16. After that, you can look at the videos and you see he makes no effort to breathe. He makes no breath. The last breath he took was at 20:25:16. Then we know after that he stayed on the street for another 3 minutes or so. Then he's placed into the ambulance, and we know that in the ambulance they attempted to put in an airway, an eye gel, and you can see that on the Officer Lane's body cam. You can see all of that happening, and then you can see the time at which they actually successfully inserted the airway and when they gave him the first breath. And that is a gap of 9 minutes and 50 seconds from when he last took a breath.
And why is that significant?
That's very significant because we can calculate what is the rate of increase in the carbon dioxide in somebody who doesn't breathe. If somebody doesn't take a breath, carbon dioxide increases at a predictable rate. And that rate is up to 4.9 millimeters of mercury per minute that it increases. And so he has not taken a breath for 9 minutes and 50 seconds. So you would expect, just on that basis, that his carbon dioxide level will go up by 49. So you add 49 to the normal values of 35 to 45, and then you add that and you're going to get a value of between 89 and above. And so it comes out virtually identical to the value that they found in the emergency room of 89.
So doctor, what's the punchline with respect to that? What does it tell us?
The significance of all of that is it's a second reason why you know fentanyl is not causing the depression of his respiration. What you're seeing is that the increase in his carbon dioxide that is found in the emergency room is solely explained by what you expect to happen in somebody who doesn't have any ventilation given to him for 9 minutes and 50 seconds. It's completely explained by that.
So when a person then is not breathing, then carbon dioxide would naturally continue to build up in the body.
Yes.
And that's what matches what was seen in the OR for Mr. Floyd.
Precisely.
Now, you said that there were other things that were significant that were related to the rate of respiration, and we talked about fentanyl.
Right.
Was there anything else?
Yes. The other things, there's two other things that are very important to the respiratory rate, because you saw it with your own eyes, exactly his respiratory rate. And the first thing is that if you have somebody who has underlying heart disease, and the heart disease is so severe that it's been said that it's causing shortness of breath, that it's causing you difficulty with breathing. If somebody has heart disease that's causing shortness of breath, virtually all of those patients are going to have very high respiratory rates. They're going to have respiratory rates of 35, 30, over 30, even over 40. When you have heart disease, that'll give you shortness of breath. Instead of that, we find that his respiratory rate is normal at 22. The second thing that's important about the respiratory rate of 22 is if you have somebody where the primary problem in the body is airway narrowing, where you have somebody where there is that the airways are being compressed, there's narrowing in the neck, or there's narrowing like in somebody in the chest, what the response, the physiological response to airway narrowing is a normal respiratory rate. And that is what he has. So it's but the respiratory rate that you see that's normal is the expected physiological response in somebody who has airway narrowing.
So, doctor, we covered the mechanisms of how low oxygen occurs. Uh, as a clinician, did you observe the results of low oxygen in the video showing the last minutes of George Floyd's life?
Yes.
What did you observe?
I mean, in terms of what we're seeing is that the changes in his facial appearance. This becomes crucially important, again, in seeing the effects of the low oxygen.
And have you seen this effect in other patients as a clinician?
Yes, I mean, because I work in an ICU where 40% of our patients die, so I'm extremely familiar with seeing people who die, unfortunately. And so when you see these changes, you see the changes in the face. It is the key way of noticing something happening is by looking at the effects on the face.
Doctor, I'm going to show you Exhibit 15 already admitted into evidence at 404. And I want to play a clip and have you tell us what it shows.
At the beginning, you can see he's conscious. You can see slight flickering, and then it disappears.
And
So one second he's alive, and 1 second he's no longer.
and could we just once more, in case Brenda went pretty fast, so jurors can see it. Just 1 second. It is 20:24:53 in the composite. Yeah, and the speed is slowed down by a third, just so we can see it. Is that the flicking
Yes,
you were
you
referring
can
to?
see his eyes, he's conscious, and then you see that he isn't. That's the moment the life goes out of his body.
I want to also show you a clip from another body-worn camera, Exhibit 43. And for Mr. Nelson, that's the Kane one. 22. That's where it starts. And I want to play this for you also, Dr. Tobin, and you could tell the ladies and gentlemen of the jury what this informs us.
Dr. Tobin.
Yeah.
My stomach hurts. My neck hurts. Everything hurts.
So now he's rocking his right side. You can see how he's moving his hip to try and rock the right side of his body to try and get air. You can see him again pushing down on the street to get air in. And these movements of his hip, you may miss, but he's having to use all his entire spine to just try and get air into that right side of the body. Keep in mind, the left side is non-functional from the way they have manipulated him and pushed him into the street. So he's cranking up his right side of his body. You can see it right there, to try and get some air into his right side of his chest. He's making repeated struggling movements. He's moving again the hips because he's using his spine to try and get those muscles to move air into the right side of his chest. And he's again trying to use his right arm, and he's unable because of the chain, the small chain linking it over to the left side. He's trying to have pushed down on that right arm into the street to try and help him, but he's unable to do it because of the chain on the handcuffs.
And at some point, Mr. Floyd stops speaking. And what does that tell us about his oxygen supply?
That tells us at that point where he's not speaking, it tells us that the airway narrowing in his upper airway is more than 85%. And then it's separate from in terms of the oxygen level that we're seeing by the face, but they're all happening together. And so once seeing how much narrowing there is in the airway, but they're all happening, they're all coming in together.
And then did the restraint stop
Right.
at the time of the brain injury and the PEA arrhythmia?
Yes.
The restraint stopped at that time?
No, the restraints continued after that. He has the cessation of respiratory efforts. When he last take a breath, the knee remains on the neck for another 3 minutes and 27 seconds after he takes his last breath. There's the knee remains. After there's no pulse, the knee remains on the neck for another 2 minutes and 44 seconds. After the officers have found themselves there's no pulse, the knee remains on the neck another 2 minutes, 44 seconds.
Thank you, Dr. Tobin. No further questions.
Mr. Nelson. Sidebar? Members of the jury, we're going to take our lunch break at this time. We're going to take until 1:30. Thank you.